In this room know that the journey we're on with interactive media and education is still early. We're at the start of it, and that the scale of what can be done in the next decade is huge. You saw Ed Vasey allude to that in his earlier speech. Well, our next speaker is Jonathan Stewart. Jonathan is a consultant surgeon who is a director of the Hollier Simulation Centre, who has some amazing ideas and imagination, and is going to talk to us about some of the unbelievable things that are being done in the health sector right now. Jonathan.
Thanks very much, Tom. Mr. Chairman, ladies and gentlemen, thank you very much for inviting me here today. I think before I start, I ought to owe up to a confession. I actually have a very limited knowledge of games. And it extends as far as this, that when I qualified as a consultant, my colleague and best friend said, get yourself a game where you can blow people up and kill things, because you're going to have to relieve the stress of operating and dealing with a sick patient every day. So my wife knows that I'm really passionate about science fiction. She went out and bought me a game where you had to fly the spacecraft out the hangar and then zap things, and you went up to different levels. And on Monday night I came home, big operating day, 12 hours in theatre. Tuesday came back, clinics, endoscopy. Wednesday, big operating day. 2 hours every night, zap, bang, crash. I came down on Wednesday night and she said, you really enjoy that game, don't you? I said, what do you mean? I said, well, there's all these bangs and crashes and you really, you're up there all night, I'm not even seeing you. And I said, I haven't actually got the plane out of the hangar yet. I gave it to the next door neighbour's kid. We represent a partnership. I'm a great believer in collaboration. And I can't actually see my slides on here, so I'm going to have to be talking up here. We represent a partnership between some big trusts, the Royal Centre for Defence Medicine, which is now changing into something else, and several other partners since then, because I don't believe that competition is going to work in the healthcare training. In the past, we used to train surgeons in an entirely different manner. We'd go to lectures, we'd do anatomy training. My first femoral hernia as an emergency, I sat in the coffee room reading the book, and then I went and did it. We can't do this anymore. In my day, I worked a 1-in-1 or a 1-in-2. That's every other night, or every other night and every other weekend for 13 years. And it's known by psychologists that it takes 100,000 hours to produce a master. We had 36 to 40,000 hours. Today, we have less than 6,000 hours. We now have to therefore look at how we're going to tell people to train, self-directed learning, and I'm going to talk to you about that in a minute, safer medicine. So if we could just play the video. This is a training video. I want you to look at the communication skills, interaction with the patient, definition of anatomy, and the wards. Can we play the video?
Good morning, Sir Lancelot. Good morning.
Here I am. I wish.
Good morning, gentlemen. Good morning, sir.
Look at the age of the training.
Not late, I hope. Not at all, sir.
Interaction with staff.
I suppose you got another half-dozen boring cholecystectomies today? Yes, sir. After last night, I feel like one myself. How about that gastrectomy I did yesterday? Not so well, sir. Oh, pity. Great pity. Morning, sister.
Morning, Sir Lancelot.
Everything ready?
All ready, sir.
Splendid.
We're not allowed to wear white coats anymore. Spotless ward.
Now, you just lie still, old fellow.
The
I'd like to
patient.
discuss your case with these young doctors here. Take his pajamas off, sister. You, examine his abdomen. Take that grubby fist away. The first rule of diagnosis, gentlemen, eyes first and most, hands next and least, and tongue not at all. Look! Have you looked? Yes, sir. See anything? No, sir. Very good, carry on. Gently, man, gently, you're not making bread. Don't forget to be a successful surgeon. You'll need the eye of a hawk, the heart of a lion, and the hands of a lady. Found it? Yes, sir. Well, what is it? A lump. Well, what do you make of it? Is it kidney? Is it spleen? Is it liver? Is it dangerous? No, worry, my good man. You won't understand our medical talk. You, what are we going to do about it? Cut it out, man, cut it out. Where shall we make the incision? Nothing like large enough. Keyhole surgery, damnable, couldn't see anything, like this. Now don't worry, this has nothing whatever to do with you. Now, you. When we've cut through the skin, what's the first substance we shall find?
Subcutaneous fat, sir.
Quite right, and then we come across the surgeon's worst enemy, which is what? Speak up, man! Blood, you numbskull! You cut a patient, he bleeds until the processes of nature form a clot and stop it. This interval is known scientifically as the bleeding time. You, what's the bleeding time?
10 sir.
Those were the good old days. We can't do it anymore. Society's changed, technology's changed. We now have multi-professional learning. We have hospital at night. For those of you who don't know what that is, that's where a team of different types of doctors are going to have to work looking after you. So you may have an orthopedic surgeon looking after you with a medical registrar when you've got your heart attack. There's specialty associations, new technologies, and that's the exciting area. The Bristol Inquiry, you're not allowed to have a learning curve. Someone's going to be the first one. In 2004, the FDA, when the Americans invented stenting for your heart and your brain, to stop strokes, heart attacks, they said, this is fantastic. You're going to save thousands of lives. How are you going to train the doctors? You're not practicing on the public. So industry had to invent simulators. In this country, you could be my first one. We have a problem with anatomy training. It's very expensive. The Human Tissues Act now says that we can actually practice on cadavers and do cadaveric operating. And then finally now, patient safety, big issue. I'll go on to that in a minute. And the European Working Time Directive. These guys can only work 48 hours a week now. If you take a week of nights, that reduces their training by even more. It's all changed with what's called the foundation curriculum. This gives explicit standards. It's competency-based. How do we assess competency? Patient-centered, team working, and communication are all now to be assessed. Now we talk about safety. Vincent is a guru of patient safety. Effectively, 1 in 10 people who come into the healthcare organizations throughout the world will have an adverse event, of which a third may die. Sunday Times, yesterday, about a child who died, and it goes on to talk about 500,000 people in the NHS, latest off the press. So we're not particularly safe. In the States, the Clinton administration organized a report that demonstrated 98,000 Americans, that's more than die from car crash, breast cancer, and HIV added together, suffer at the hands of medical errors. In the UK, $2 billion a year on problems due to medical error. So anyone go bungee jumping and mountain climbing, you're a bit safer than coming into the NHS. Liam Donaldson recognized this and therefore produced his report and has mandated that simulation training now has to be introduced into healthcare training, right across the board. It needs to be valued by the organizations that we work for, and this is critical. You have to have a trained faculty. You can have the world's greatest simulator, but a bad debriefing or a poorly trained instructor will render it meaningless. The House of Commons Select Committee, human factors training, now has to be mandatory and introduced into healthcare training. And finally, now the government are producing a report. I'm part of a working group that's advising them, and simulation training has to be integrated into training. It has to be done within a curriculum. We know that simulation hits the doing bit. It hits the triggers. You've just seen that fantastic presentation. Gaming has a big role to play in training. Standing there lecturing now isn't going to work, especially in an industry such as surgery. What are the advantages? Well, we're not going to harm the patient. We can learn in a safe environment where the trainee's not going to get hurt. But we did have once a trainee when the mannequin that we were using was having a cardiac arrest, and the old-fashioned defibrillators that you see on the ER, and they go boom, and he stood there with one next to one ear and one next to the other. And so we had to gradually stop the thing, and it wouldn't be good. Consultant surgeon fries trainee's brain. It would be very bad, very bad. We can keep doing it until they get experienced, and we can work with other professionals. Doctors train one way, nurses train the other. The first time they start working together is on the wards. Well, it's a bit late then to try and teach them how to work as a team. We can keep on going until we can attain mastery. And it's safe. We learn from mistakes. Everybody learns from mistakes. There are real disadvantages. It isn't real, and you can get some people who are in denial. And that's quite difficult. It costs a lot in terms of training your faculty and in terms of the outlay, capital and revenue. We can also, apart from the clinical skills and the technical expertise that we have to develop, look at now the non-technical skills. And this is critical training that we're learning from high-risk organizations such as the aviation industry, where we look at team leadership, decision-making, and situational awareness, all of which contribute to error. We can start looking at diagnostic fixation, where the doctor gets perceptual tunneling and can completely diagnose the wrong condition. And so you'll often see first-year doctors called to the ward, and they'll confuse post-operative hypotension due to lack of fluid with hemorrhage. And that's universal. By using a simulator, you can actually improve their performance. We can factor in stress. Medicine and surgery is very stressful. You can't do that in routine lectures. So we can train the doctors and nurses how to perform under stress. And we can train them, therefore, how to avoid errors which they won't see because they haven't received the specific training within teams and stressful situations. And it's in the stressful situations that things go pear-shaped. We also, therefore, have to pick the appropriate use of simulation. Simulation is really sexy, and you get people coming along, and I find them in the center, and what are they doing? Oh, they're going to use simulation to train. Oh, right. And it's completely inappropriate. You have to pick your modality to make sure it is actually valid. And in some cases, it will be a laptop. In other cases, it will be a role play with a simulated patient. And in other cases, it may well be a mannequin. There will be a modality and multiple modalities that are required. Poor slide, but we're going to take simulation from having an orange with a nurse, giving an intramuscular injection, through to your area of games, into the high-tech mannequins, which will physiologically respond. So the mannequin will respond to the appropriate drug, the wrong drug. If the trainee kills the patient will die. And we can take it whichever way we want. So the mother with the simulated actress can run into the A&E department with the little mannequin, the baby having an asthma attack, and the baby dies. But the actual scenario is, how are they going to deal with the mother? And that's something you can't train. That's something that's going to happen in real life. And we know that when young trainees go into an emergency department, up to 20% of them can be psychologically traumatized because they're simply not used to dealing with such a stressful environment. A simulation center is all standardized. Here's a picture of ours with a mannequin in a ward environment, one-way mirror, control room where we run the whole situation, and that's where the learning takes place, in the classroom, where others will be watching it. And then we teach them metacognitive skills, the ability to dissect a process for their improving performance. I'm particularly interested in the high fidelity training, looking at teamwork. So it could be a theatre or an obstetrics unit. In obstetrics, you've got a very stressful workload. Everything's working on this one. You've got paediatricians, you've got anaesthetists, you may have surgeons. I was called recently to do an operation on a high-risk woman with spina bifida and had previous bladder surgery where they'd reconstructed the bladder using a loop of bowel. And I arrived to find a bit of conflict going on in the theatre with the anaesthetist snapping at each other, the midwife and the paediatrician snapping at each other, the urologist and the obstetrician a bit lost. So I scrubbed up assessed the situation, started operating, and decided that actually what they were trying to remove wasn't the uterus, it was the artificial bladder that had been created. So I suggested that we work like this, and as I was just dissecting onto the uterus to get it all up, this finger came down in front of me. And it was a urologist trying to help me. So these can be very challenging situations. High-risk pediatrics. The young doctor gets qualified, goes onto a pediatric ward. He's never actually dealt with a baby before, and there he is dealing with your baby. It might be better if he practiced first. First time you transfer a patient is when you're doing it. And there have been all sorts of cases, from the oxygen cylinder running out in the helicopter because nobody checked the oxygen cylinder, to nobody's actually taught the junior doctor how to take the brake off the crash trolley. So you see him dragging the crash trolley. To the patient having a successful operation and he's being wheeled up to the intensive care unit and he goes in the lift and the lift door's shut, but unfortunately the porter stood outside with the oxygen cylinder. It's better they practice. And then in the military, how do we train our doctors and nurses to look after the trauma in the military? The Americans facilitate the practice because they shoot each other. We tend not to do that. So we really have to use Manikins. There are various other exercises that I can't mention because I'd have to shoot you if I did, all of which are not really good for team building. So the military is what we're working with, looking at a variety of areas. Because the GDMOs, the second-year doctors that go out, they may not even have been in an operating theatre. So there's a lot of interest in, especially point-of-injury casualty training, then moving along. Because once they get to here, they get the best. But this bit is the area that we think simulation will probably be able to help our military colleagues. And it'll have to be a civilian-military cooperation, and I'll talk about that. This is the area you're interested in, but I'll draw you can't read it. But William Mayo was a very famous surgeon. In 1927, there is no excuse for a surgeon practicing on a patient. 1927. The big games, surgical training can become just a lower cost than existing methods. Well, I trained for a year in France when keyhole surgery started, and I was privileged to work with some of the great guys who invented it, and I had to work on a simulator before I went anywhere near a patient. And when I came home, I was working with my professor, and we were doing a gallbladder operation. He made a hole in the bowel. You're not supposed to do that. He made a hole in the bowel. And he'd clearly been watching some videos, so he sutured it. 38 minutes. I thought I was going to die. And I looked at him and I said, Professor X, do you think I could have a go? He looked at me and said, go on then, 28 seconds. And he looked at me and said, how did you do that? I said, I wasn't allowed on a patient until I'd been in a simulator. He went and bought one the next day, trained himself for 2 hours every night, and could wang in a stitch. Since then, all trainees went on a simulator in his unit. You know all the other theories. Reducing errors. Laparoscopic surgery, as I've just said, came on. It was the first one really in British surgery that games started to come in. It's proven, it's validated, it works, it's great. Anatomy training is a big problem. So now there's virtual reality anatomy training. In Colorado, they've got a beautiful one where it's a 3D, you can walk in and walk around it. The use of virtual environments for chemotherapy, for children having post-operative procedures. All these can be utilized. Virtual autopsy. Autopsy rates in the UK are dropping for a variety of reasons, but how are we going to train the pathologists to do autopsies? So by a combination of game, MRI, CT. A big one in the States that I've been working with. How do we simulate and protect, especially with the Olympics coming up? I'll talk about that. Use of strokes. This is a device whereby you're training the affected side of the brain to be able to react. And in the military, there's huge areas from combat trauma, situational awareness. This is in a smallpox, distance education, distance training, breaking down, because you don't want your doctors into the area where the smallpox is. Drilling holes in brains that have been shot, and the management of fractures and severe hemorrhage. All these are games. New technology. Here's a woman who's got a big berry aneurysm. This is an aneurysm in the brain. If this bleeds, she will die. In the old days, well, today, the standard way of treating this is to lift a whole craniotomy flap up, do the procedure, get out. Today, a 2-centimetre incision above the eyelid. Small instruments go in. How are you going to train the guys to do that? They've got to have some form of virtual reality or haptic procedure in order to do this. This guy's a neurosurgeon in Canada. He's done over 200 now. They take the patient with a brain tumour. They image it. So they'll do an MRI, a CT, an angio, so they know where the tumour is, where the blood vessels are. They've implanted that into a game where there's a human brain, and then he has a game with haptics. So they actually practice the operation live several times, and then they do the operation on the patient. So we've actually rehearsed your operation. So there can't be any surprising cuts of blood vessels because they're around the back, because we can't see them. We've already practiced it in a 3D game. So in the future, we're going to have to look at haptics, the actual graphics. A lot of companies have been to see me and saying, we've got this fantastic thing, it really is real. And I said, well, does it need to be real? Can you do it on a more simple level? We need to be able to make tissues feel like they're being cut or cauterized. Because medicine is definitely going to need more training in multidisciplinary teams. There are a variety of themes that I've mentioned, because also we're getting much more complex cases. We're operating on people who 25 years ago probably couldn't have had surgery. Technology is driving it. This is going to diffuse all the way through, and ultimately patients are going to expect it. Patients are going to expect that we've actually rehearsed our procedures and been trained on some form of simulator, just like a pilot. So you're going to see multi-modalities, simple PCs, Manikins, virtual work-based trainers for putting cameras into people's various orifices, down to high fidelity. It'll be a spectrum. Our program, we're training 1,400 junior doctors in the West Midlands. And we're now training fifth-year medical students. And we've got a whole series of other developments in the pipeline. Mobile training, we take the Manikins, we take the cameras, and we can train on site. And on Monday, with the Olympics coming up, we trained with some of the emergency response teams, paramedics, firemen, and we take them into the building so they can train it. And one of the concepts I have with Professor Stone, who many of you know I worked with, is why not have a virtual reality game whereby you can make for every stadium that the Olympics are going to be in, fill it full of smoke, whatever you want to fill it full of, to train the paramedics and the emergency response teams and the military, if necessary, where the robots to go and defuse a bomb will have to go, and then we can add it as part of a curriculum, as opposed to separate modules. So the future is simulation, and serious games are going to play a big role in it, from everything. So I think PowerPoint's gone now. It's going to be learning by doing. So if we can slightly draw to an end, it's got to be curriculum-based. It's no good just producing a game or a mannequin or a course. In order for it to be sustainable and educationally viable, it has to be within a curriculum. There will be multiple technologies, and it ultimately will be part of assessment and accreditation. And what we want to do is fire up our trainees. We want to get them really excited and passionate about becoming better doctors, better nurses, safer doctors, and safer nurses. So, in conclusion, I think your industry is poised to do dramatic things about education and training through the whole of society. From reducing maternal mortality in Africa, where a woman dies in birth every minute. I've got an idea for a game there, if anyone's interested. To training surgeons today. I think you've got a very exciting future ahead of you. Thank you very much.
Jonathan, you'll take questions? I don't know about you, I feel a bit queasy after that. I couldn't help thinking, Jonathan, there's a colleague of mine called Keith Vaz, and had you say to him, I've got this idea for a simulation where you drill through the cranium of somebody's head, he'd be calling for this stuff to be banned. So don't come to Parliament too often. Look, that there was a lot of scale in that, and I find that inspiring, and it really does show that we are on the tip of something very big in this area. Are there any questions to Jonathan before I do some announcements? This gentleman over here with the glasses. I should just say, if you could introduce yourselves and say where you're from now on, if that's okay.
Paul Hollins. I'm a switched, yeah. Paul Hollins, I'm director at the Institute for Educational Cybernetics. I'm just quite interested in how you might respond to findings that are coming out the US Department of Defense in terms of use of simulation for communication training and a direct correlation with increase in friendly fire. I just wonder whether there are any implications for health in that.
I didn't quite catch it. It's a bit muffled up here. Say that again.
Yeah, there's some evidence coming out of the US Department of Defense where they use simulation for communication training, particularly for a correlation between the use of simulation and an increase in friendly fire due to desensitization, apparently. But I just wondered how you might comment on that.
I don't think there's sufficient data to be able to say one way or the other at present. What I would say to you is, looking at the human factors side of it, errors are usually due to system failure rather than the individual. So I think when you start to actually you can't take simulation without human factors. It's got to be part of a curriculum involving human factors and how we function within the environment. So the data's out on that. It'll be due to communication and stress and the non-technical skills, all of which are now in surgery, for example, in anesthetics. We now have a scoring system for validating how the performance of the team is, how the performance of the individual is. So I'd step back and wait for more data, to be honest.
Okay. Any other questions to Jonathan?
I can go.
No? Okay, Jonathan, thank you. That was wonderful. Okay, so before I wrap up for coffee, I just want to say I hope you found those 3 different presentations as interesting as I did. Jonathan showed me about how high fidelity training is going to change the way people do business in the health service. The nearest I've ever got to that is role-playing cesarean at NCT classes with my wife, and that was pretty traumatic for me, but came in very useful as a parent to be in the delivery suite. I won't go any further. And then we saw what it's like to give away your creativity and how that can foster an unbelievable explosion in innovation from our friends who designed Little Big Planet. And then you saw at the start Ed Vasey sketching out his vision for where he thinks the UK games industry can mesh into government. I hope you found that a good starter.